Okay, the next the last speech will be presented by Dr. Wang Zhenyu. She was graduated from Department of Pharmacy, National Taiwan University, and received master degree of clinical pharmacy and the PhD degree of pharmacy from National Taiwan University. He has clinical and research experiences before becoming the current research staff. He is now the Assistant Investigator of National Center for Geriatric and Welfare Research, National Health Research Institute, Taiwan. Her research interests focus on polypharmacy, osteoporosis, pharmacoepidemiology, health, economic and outcome research, and community health promotion. She won several research awards, and I believe she will become a star in the near future. Today, she will give us a talk titled as a Patient-Centered and Engaged Medication Optimization Project to alleviate drug-related problems in community-dwelling older adults. Let's welcome Dr. Wang.
Thank you for that kind introduction. And good afternoon, ladies and gentlemen. This is Jane Wang from National Center for Geriatric and Welfare Research. And today is my honor to be here and present my study about my pharmaceutical care. That is a patient-centered engaged medication optimization project, which in order to alleviate drug-related problems in community during older adults. I have no conflict of interest to disclose, but I want to acknowledge all the financial support from our Center for Geriatric Welfare and National Health Research Institute, and also the National Taiwan University Hospital Unit Branch. And in the beginning, I want to introduce the HOPE study, because our pharmaceutical care is under the infrastructure of the HOPE study. And the HOPE is named from its study aimed to improve the healthy longevity and aging in place, which is a community-based multi-domain health promotion program under a cluster randomized control study design. And launched in September 2021 in Yunlin, a rural county in Taiwan. And we are now here in Taipei, and Yunlin is in the middle Taiwan. So there are some pictures of Yunlin. The Yunlin is agriculture-based and with a large age population, while related rural with poor transportation. And this makes it more difficult for the elderly to search for their medical cares and even the daily nutritious meals. So therefore, the governments in Yunlin launched the congregated meal service in the community activity centers. As the picture, you could see the elderly could gather together to enjoy their lunch and to conversation with his neighbor and friends. So this service is very popular in our elderly people. And by this way, we could also deliver various healthcare promotion activity directly into the community. Healthy longevity and aging in place, the HOPE study integrates the osteoporosis, sarcopenia, risk assessment and treatment, and also the nutrition evaluation, polypharmacy intervention, exercise training, and also welfare support. And in this today's presentation, I will focus on our pharmaceutical care, mainly to alleviate the drug-related problem and anti-cholinergic burden. The study integrates total 30 communities in Yunlin, and until now it already performed for 2 years. And in these 2 years, we have hundreds of health evaluations in the communities. And you can see the picture here. The bus is the DESA bus. Then we drive the DESA bus directly into the community. And this is very interesting that in Yunlin there is many temples. So it's a very very interesting finding. You can see the advanced technology together with the traditional agriculture. Okay, so during this part, we do many screening. Sorry. Many evaluation, and after the evaluation, we will provide them the feedback reports about the lectures and many interaction with the elderly in the community, and also introduce many kinds of exercise training programs in the community. This is the conceptual framework of our pharmaceutical care. And first, our geriatric research team will collect the data from the elderly in the community directly, including their baseline characteristic, drug information, adverse drug reaction, and interview for their adherence. And this information will sent back to the pharmaceutical care team in National Taiwan University Yunlin branch. And the pharmacists there will go the comprehensive drug review, especially for their drug-related problems and also their anticholinergic burdens. And then we will feedback in the community by giving the patient-specific reports, a one-on-one consultation, or the healthy literacy promotion. Under a cluster randomized control study design, it means the elderly are included in the study after their drug information collection. They were randomized into the pharmaceutical care group and the usual care group. And both groups will undergo assessment. However, only the pharmaceutical care group will receive the interventions. And we measure many outcome but in this presentation, I only focus the drug-related issue. Okay, and this is the concept of our interdisciplinary community-based care model. It contains 3 steps. The first step is data collection in the community, which was performed by the pharmacy and nurse in the community. And then in the second step, the evaluation and advice were performed in the clinical pharmacy in hospital and sometimes the physician. And they will identify DRP and anticholinergic burden, evaluate the benefit and risk, and generate advice and care plans. And finally, we will feedback to the in the community, and that was performed by the pharmacist and nurse in the community. And we will deliver advice and sometimes one-on-one consultation and follow-up for further assistance and clinical outcome. And in this study, the pharmacists were designed to the same community in order to establish the stable relationship and familiarity between the pharmacist and their the elderly in the community. And there are some pictures of our interventions. And this is the baseline characteristic. The mean age is about 75 years old, and the female is the majority. And there are almost 45% of patients living alone or living with spouse, and nearly 65% of them with low education level, lower than elementary school. And the most common comorbidity is hypertension and diabetes. And worthy to know is over 50% of them with poor medication adherence and polypharmacy. So we focus on the drug-related problem because it contains all problems which will interface the effectiveness and all the safety of the drug therapies. So in our data, we found polypharmacy was increased almost 5.5 times risk of the DRP, and DRP will also increase almost 2.5 times risk of the composite outcomes, including the 4-factor unplanned hospitalization and death. So we use the Pharmaceutical Care Network Europe, DRP coding system to systematically classify record and effectively treat our DRP. And this is a common language for communication or research. So all the problem can categorize into the treatment effectiveness related or treatment safety related. And all the problem were defined in 5 components about the kinds of problem and also their causes of problem and the intervention we give and the acceptance of the patient and finally the outcome status of the DRP. So this is the 1-year result. We identified about 300 DRPs in this study. And we could find the most common type DRP is adverse drug event possibly occurring. And the other one is the effect of drug treatment not optimal. And the causes, the most common cause is patient's behavior related, and the other one is the drug selection, and the third one is the treatment duration is not optimal. So in our study, we found in rural community, patient-related factor that deteriorate problem of polypharmacy is all kinds of factors such as like their low health literacy and double frailty spouse, and also their healthcare fragmentation and poor drug storage habits, and also their self-acquired over-the-counter drug, herb, and supplements. And finally, is their limited care resource or transportation, or will introduce some drug-related problems. So we document our drug-related problem every 6 months, and you could see the number of drug-related problems accumulated. And if the problem is totally solved, it will located in the upper right corner. So you can see in the pharmaceutical care group, there are 65% of DRP solved in the 12 months. However, there was only 30% in the control group. So we do some previous research analysis. We found between the 2017 and 2022, a previous research addressing the DRP, and they adopt the PCNE DRP system to document their DRP. Most of this study is launched in hospital or nursing home, and under a single arm before and after study design, and with fewer sample size and low follow-up period. However, and it's worthy to know that only 6% of this previous research report the outcome of DRP. So the pharmaceutical care of hope is a real, very cherished program because it can take place in the rural community and under randomized control study design and with a repeat is a regular follow-up every 3 to 6 months for total 48 months. And we do many interventions to the old people in the community, so we could check their outcome status of DRP. And in the second part, I will share the anticholinergic burden because in this year's conference theme is the biomarker. So I wonder where there is a biomarker in my epidemiology and implementation research, but I think the acetylcholine is a kind of biomarker, and I think the drug which inhibits the acetylcholine and contribute to the anticholinergic burden is also a kind of a marker which is associated with many negative clinical symptom outcome. So I will present some study about our anticholinergic burden assessment. So just like the picture, the drug with anticholinergic burden will result in the elderly make them feel very hot and sometimes tachycardia or or shaker or dry mouth, constipation, or blurred vision is a common side effect about the pharmaceutical care. And previous very well-established evidence has shown that drugs with anticholinergic effect were associated with many kinds of negative outcomes, such as the decrease in cognitive or physical function, and also increase the fall and emergency room visits. And if the patient was used one or more medication with anticholinergic effects, they could have the accumulated effect of anticholinergic. We call that anticholinergic burden. It means ACB in this study. So there are many important evidence that do research and published in very nice journal already show that anticholinergic burden was associated with factor-specific hospitalization, dementia, and recently the researchers in National Cheng Kung University doing a very nice, very sophisticated study design to evaluate the current use of anticholinergic burden may increase the risk of acute cardiovascular events. So there are many nice real-world evidence now. But in addition, in our study, we want to understand the anticholinergic burden and the intrinsic capacity, the association. Because when we lose the intrinsic capacity, the older people may characterize by the manifestations such like difficulty in hearing, seeing, activity, impairing in nutrition intake, and cognitive function. So this is the figure show the 6 main domains of the WHO proposed intrinsic capacity. And because the medication with anticholinergic effect was associated with the decline in cognitive function and visual disturbance, so we want to see whether there are the association between anticholinergic burden and IC. And this is the baseline association, the baseline screening of the IC and baseline screening of the anticholinergic burden. And we could see when the anticholinergic burden increased, the IC score decreased significantly. And the phenomena is similar in all six domains, including the cognitive, limb mobility, malnutrition, visual impairment, and hearing loss, also the depression symptoms. However, there is only visual impairment and hearing loss have the statistically significant difference. And in this, and furthermore, we see the change is the longitudinal follow for 1 year. The change of the anticholinergic burden and the probability of intrinsic capacity progressed. And you could see that when the anticholinergic burden decreased compared to ACB no change, the anticholinergic decrease can significantly increase the intrinsic capacity, especially for the cognitive progress. That is statistically significant. So, just like previous mentioned, there are already many evidence show that anticholinergic burden was associated with many negative outcomes. However, intervention in reducing ACB are still very rare. And from 2010 to 2019, there were only 8 studies address this issue. And this study all launched in urban or developed countries, or in a single hospital or nursing home with small sample size or short duration. Most importantly, this study without patients' involvement or preference. So in this study, we want to evaluate whether an interdisciplinary long-term community-based patient-centered pharmaceutical care model could reduce the anticholinergic burden in community during older adults. So in this part, we need to do the polypharmacy prescribing. There are 3 steps. The first step is we need to do the comprehensive drug review. And the second step is we need to identify inappropriate prescribing. And there are many tools can help us to identify. And we assess each medication for its eligibility to be discontinued, including no valid indications, part of a prescribing cascade, or the harm of a medicine clearly outweighs a potential benefit. And most importantly, is the symptom control medication is ineffective or symptoms have completely resolved. And this item is the most identified in our study, our trial. So, and in the third step is we perform the prescribing. We need to prioritize medication for discontinuation, and we implement and monitor medication discontinuation regimens. So there are many kinds of anticholinergic risk scales, and in 2015, Salahaden's researcher, they do a systemic review and they propose a composite rating scale. So in this study, we use the composite 1. So we have 4 steps to describing our anticholinergic drug. The first step is identify anticholinergic drug. We use the Salahaden's proposed one in 2015. And in second step, we prioritize AC drug for discontinuations. We classify AC drug into 2 types. The first one type is the R type, which means this kind of drug is regularly used for chronic disease control according to clinical practice guidelines and evidence, such as the metformin, atenolol, diazoxide, or metoprolol. And the other kind is the S type. It means the drug used for symptom control, and patient could recover from symptoms, or the symptom could be modified by a specific treatment or lifestyle changes, such as the NSAID, antihistamine, or anti-ACE. So in the third step, we will identify whether there is any potential side effect. If the side effect exists, we will discontinue or switch to another AC drug or decrease the dose. And if there is no side effect for the R-type AC drug, we will continue and monitor. And if there is, and however, for the S-type AC drug, we will go further to understand the benefit and risk of the drug for the patient by face-to-face consultation, including we ask whether the indication exists or the drug improves their symptoms, and also the patient's actual use of the drug, and also patient's preference. And all this information together can help us to make the final decision about the discontinuation. Okay, and our primary outcome, we try to measure whether the proportion of discontinuation of AC drug after 6 months of intervention. And the discontinue means there is no prescription for the medication or the use of medication less than 3 times within the last month. Okay, this is our result. We found that among our elderly, there are 46% of them prescribed with medication with anticholinergic burden. And among this drug, when we categorize them, we found there are 66% of them is R-type and 33% is S-type. And the most used R-type is the metformin, atenolol, and diazoxide. And the most used S-type is the celecoxib, tramadol, and cassisoprol. So the discontinue rate of in the 6 months is about 22% in the pharmaceutical care group. And however, there was only 40% in the usual care, but there is no statistically significant difference. However, when we stratify the anticholinergic drugs into R and S type, we could see because S type is the kind of drug we focus. So we found the discontinue rate is high. It's almost 60% in the pharmaceutical care, and there was only 35% in usual care. So, and there is a statistically significant difference. So this is the first community-based trial to manage anticholinergic burden in rural area, and we found the categorization of ACD could help us prioritize the medication to prescribe. And in addition, we found shared decision-making between the caregivers and the older adults is important for the prescribing. Okay, I want to share a slide to everyone here because I think everyone is doing very nice research. And in my field, I do the implementation of our implementation science research. So we found many difficulties happen always. So you have to face solve problems when you are you unexpect. So in our study, we found that the most important difficulty we need to face is the limited human resource and large time consuming. So, and next I will introduce our electronic supporting system. And this system is not in my study plan, but I need to develop this in order to do better pharmaceutical care. So in our study, we have several steps to screening, evaluation, and feedback. And the first, in the community, we collect their data. And the second step is we need to transcribe and interview survey results one by one into documentation, and also integrate cloud-based medication history. And the third step, when we deliver this information to the pharmacist, and the pharmacist do assessment, they review and assess the characteristic of each medication and scoring them individually. But because the information is heavy, so they need to survey results from different workshops. And finally, when the pharmacy finally do their evaluation, complete their evaluation, we need to do the pharmaceutical data compilation because we need to calculate score for various pharmaceutical indicators and also establish a base report of the result in the community level. Because when we go back to the community to do the feedback or the consultation, we need to face all the community elderly. So, and finally, we generate personalized feedback, just like picture here. We will give each our elderly their personalized advice. And the table in the right hand shows when we do the consultation one-on-one, we have need to do the summary of their medical record. And this the processing of this table is very time-consuming. And finally, we feedback in the community. And however, every time we do feedback and consultation, we will get more information. So when we come back to our office, we continue to key in many information, such like their drug-related problem outcome and their their self-preference of the discontinue of medication, etc. So it is the summary of our community screening for the pharmaceutical care. And this step will repeat every 6 months. So it is lots of manual works. So we try to develop medical tracking system in a digitization operation. The objective is to automatic processing and make our service more time efficiency. Okay, so this is the drug, our medication tracing system, the interface, and the electronic health supporting system will automatically assess the characteristic of each drug, score them, and generate statistical reports. So we found that when we use traditional operation, we need almost 1.5 months to do all this evaluation. But when we use the digital operation, we only need about 2 weeks to finish all the steps. So it is very important for us to do more service and more timely and efficiently. Okay. This is my conclusion. So the drug-related problem was very serious in elderly in rural community. We could see they are living, 20% of them living alone, and 30% is illiteracy, and over 50% with poor adherence and polypharmacy, and nearly 60% of them with anti-cognitive burden. So the community-based pharmaceutical care model, which engage patients in shared decision-making process, or prioritize drug for discontinuation, such as the RNS type, and through the interdisciplinary teamwork and long-term assessment follow, could effectively improve drug-related problems and reduce the burden of S-type AC drug. And in addition, the ACP decrease was significantly associated with cognitive function improvement. So in further strategy for managing declines in IC should monitor the use of anti-cognitive burden drugs. And finally, to deliver care efficiently and timely, an electronic system for pharmaceutical care is important. Okay, and I want to thank all the supervisors, doctors, and pharmacists in the National Taiwan University Hospital Yunlin branch, and also our National Health Research Institute, the HOPE Research Group members. And thank you for all your attention.
Thank you for your interesting talk. I'm wrong. You will become a superstar in the near future.